Yeah, so for this final session, new treatment strategies, I'm going to give you an idea of not so much what you can do right now, but trials that may be coming to an intensive care unit near you. My disclosures you've seen before, some of them do relate to what I'm going to talk about. But as I said, this isn't about, I'm not suggesting what you should do tomorrow or next week when you go back to your intensive care units, but what might just be there in the future. And I'm going to start with actually something that you could actually do in your ICU and go back to where I left my last talk around inotropes and mentioning the Leopards Trial. So if you weren't in the last talk, just to remind you, this was a phase 2B trial, we would say, looking at levosimendan for the treatment of septic shock. And to summarize the results, we were looking at the effect on organ function, and we saw no improvement. In fact, actually, the SOFA score tended to be lower over their ICU stay in the patients treated with placebo, mainly due to the extra norepinephrine that we'd used. But as I was saying last time, many people have said, well, that was all patients with septic shock. Surely you didn't expect everybody to benefit the same way, and we agreed. And as I said, this was a phase 2B trial. So we were looking for, could we identify patients who were more likely to benefit that we would take forward if we did do a phase 3 trial. And so we included these subgroups, that what we thought potentially high-risk groups where we might see more benefit, if they had low cardiac output, if they had impaired oxygen delivery to the tissues, or if they're on high-dose catecholamines. And you'll see, as I've shown you before, there was no sign that any of these subgroups got any benefit. This is published in the supplement of the main paper. But we've since done some more work, and this is currently unpublished. It's under review at the moment. But looking at cardiac biomarkers, again, could we identify the patients who might benefit? So we used troponin as a marker of myocardial injury and NT-proBNP as a marker of myocardial dysfunction. And was there any benefit? We used sort of normal levels and above the normal levels, or even we took them as the median. These were our planned subgroups. You again could see, looking at the mean SOFA scores here, there was no groups who benefited. And in fact, if you actually look at it, the patients with the higher proBNP levels, i.e. with the most myocardial dysfunction, actually seem to be doing worse with the treatment. So this is sort of part of the evidence around. In my last talk, I concluded that I try to avoid using inotropic therapy. I used to think it was that we should avoid the beta agonist, but I'm beginning to think we should avoid inotropic therapy and just wait for the heart to get better, the myocardial dysfunction to recover. But of course, this has raised the question of, actually, if we shouldn't use beta agonists, shouldn't use inotropy, should we use the sort of opposite and use beta blockers? And of course, I'm referring to Andrea Morelli's study published a few years ago now in JAMA, where in this fairly small study, only 150-odd patients, but he found a remarkable difference in mortality between the two groups. As you see, mortality was significantly reduced from a very high control mortality rate group when he gave these patients beta blockers. Now, I think it's important to read the paper in detail and understand who he studied, as well as the mortality effect. He saw that there was improvement in hemodynamics. Obviously, the heart rate was the target, it came down. But the norepinephrine dose he showed was able to come down as well. So perhaps counterintuitive that it actually improved the cardiovascular system. As I was saying, looking at detail on who he studied, it was patients who were in septic shock who had already been resuscitated, had adequate fluid resuscitation, and were still tachycardic at 24 hours. So this wasn't in the early phase of septic shock. This was at least 24 hours after they'd been fully treated. And again, he made sure that they had no dysfunction measured by the cardiac index here, had to be at least above 2.2. They were also a very sick group. I don't think from what I can tell, it wasn't an inclusion criteria, but these patients were on reasonable doses of norepinephrine, a median dose of around about 0.39. So it was a very select group of patients he was studying. Now, I still don't think, despite these results, this is ready for everyday clinical use, even if you were to use it in these select patients. This was a single-center trial, not huge numbers of patients. It had to be open label by its definition, though, titrating to heart rate. You can't really blind that. But as I said, a single center with an enthusiast. And we've seen these trials before that have given us perhaps data that isn't externally applicable. So we view it needs to be tested again. And this is what we're doing now in the UK with a new trial that's underway. It's known as the Stress-L trial, run by the UK Critical Care Research Group, funded by the NIHR. And a colleague based in Birmingham, Tony Whitehouse, is the chief investigator. So we're looking to see in a multi-center trial, we're using a different beta blocker, landiolol, another short-acting drug. Do we see the same effects? And I think we need to see these more trial data before this becomes part of our clinical practice. So that's a bit about hemodynamics. What other therapies? Well, I'll go back to the anti-inflammatory therapies. And this fairly simple cartoon showing about our theories in the past around how cytokines drove the inflammatory response in sepsis. And of course, we've tried to block that. And of course, a lot of that work was done around blocking TNF with monoclonal antibodies, but we saw no difference in outcomes in the patients. We tried the receptor fusion proteins to bind the circulating TNF, and again, no difference in outcomes. Tried to risk stratify the patients and only give it to the high-risk patients here with the most inflammation, the IL-6 positive. Worked as a risk stratification, but again, no difference between the treatment and the placebo-treated patients. In other studies using, again, receptor fractions, low doses, it made no difference, and at higher doses, the patients actually seemed to do worse. So these are all studies, old studies you're probably familiar with. And sort of idea of treating TNF, anti-TNF strategies in sepsis, although they work in other inflammatory conditions, seem not to be applicable for sepsis. But is there an alternative? Well, we need to think about the TNF signaling in a bit more detail, and we understand a lot more than we did perhaps when those trials were conducted. TNF binds to two receptors. TNF-R1 is the smaller one, sometimes known as P55, and a bigger receptor, P75, or TNF receptor 2. And these receptors have different functions. So TNF-R1 is present on most nucleated cells and leads to pro-inflammatory gene transcription, and it has a death domain and leads to cell death. The TNF-R2, on the other hand, is really only present on immune cells, monocytes, and it doesn't have the death domain, and it can actually lead to cell survival. There's a lot of crosstalk between the two receptors, and so just signaling via different pathways ends up in different outcomes. This is demonstrated by colleagues of mine at Imperial, Mike Wilson and Masao Takata, looking in mice, and they've taken a ventilator-induced lung injury model where they overventilate these mice. And if they have wild type or they knock out both of the TNF receptors, you see over this injurious ventilation, airway pressures go up. If they knock out the TNF-R1, then the mice are protected. They don't get these increase in pressures, and when they look at alveolar permeability, it goes down. It seems to be protecting if they knock out the TNF-R1. On the other hand, if they knock out the R2 alone, then that's injurious, suggesting that the TNF-R2 is playing a protective role. So it would seem you don't want to block out both receptors, only the TNF-R1. And can you do that? Well, you can. There's antibodies been developed that will be selectively binding to just the TNF-R1 receptor, and so block signaling in that pathway, and not the TNF-R2. And interestingly, these antibodies they've developed are this domain antibodies, very small. That actually means that you can give them nebulized, and you may be able to get effect within the lung without having to give the systemic effect, which may be another advantage. And certainly this has been done, again, in the animal models at Imperial, where they've given this domain antibody, and they were able to protect the lungs from this injurious ventilation where the elastance didn't go up, the oxygenation didn't drop, and the protein in the BAL fluid was also lower. So it seems to be that there may be a protective role. And just recently, this has been published earlier this year in Thorax from other UK investigators led by Proudfoot at Barts in London, where they've done a series of studies. The first one here I'm showing is an in vitro model where they've used this antibody, which is the third line across. And you can see it reduced neutrophil infiltration, transmigration in this cell assay, and the cell surface receptors that act as chemoattractants were all reduced when you gave this domain antibody compared to when you didn't give it or you gave a dummy antibody. They did it in an animal model, and then they went on, I think, much more importantly, to a human model. So this was giving healthy volunteers an inhaled LPS to get a mild sort of lung injury, and they had the domain antibody, and also had a bronchoscopy. And they were able to show reduced neutrophil infiltration and reduced cytokines in the BAL fluid of these healthy volunteers. So I think it's an important aspect of our trials now, not just taking animal model, using human models to go forward. Now, clearly, these are still healthy volunteer models, but clinical trials are underway. This is one that's been running in the UK, looking at giving this domain antibody to patients undergoing esophagectomy with their one-lung ventilation. Did it help protect and reduce inflammation? And hopefully other studies are planned to be done soon. But going back to that inflammatory cascade I showed, a very simplistic version here makes it nice and pretty and understand, but actually it's much more complicated than that. It's probably much more like this. In fact, this is probably an oversimplification at all. There's a whole network of different pathways that interact. And it's probably unlikely that blocking a single molecule is likely to be effective. And as we know, the whole sepsis definition has changed recently, and recognizing it's a dysregulated response. So it varies in different people. And so therefore, we may need alternative therapeutics. And what many people are getting interested now is about the idea of using stem cells to treat sepsis or ARDS. And there's lots of review articles looking at this and suggesting they could be beneficial because they're able to reprogram immune cells. And there may be multiple effects that they have that could be a benefit in our critically ill patients. For the sake of time, I can't go over it all, but maybe this review article you'll find interesting. And it describes the potential benefit effects that's been seen in animal models where they have anti-inflammatory effects, regulate endothelial and epithelial permeability, increase alveolar fluid clearance, which may be important for the ARDS studies. And for sepsis, antimicrobial effects have been described as well as anti-apoptotic effects, and effects we still don't fully understand, but have been described with little microvesicles that pouch off the stem cells and direct transfer of material and mitochondria between cells that may help in repairing organs that are damaged. So, are we going to be giving stem cells? Well, first of all, I think we need to know whether it's safe. So this is a lot of the work in sepsis is being led by the Canadians and the Toronto group in particular. And they've done this review of studies in the acute setting. So this is not all sepsis or ARDS. There's myocardial infarctions, there's strokes and so on, where they've given it. And they looked at the side effect profiles. They concluded it's fairly safe. It's relatively small numbers, but I don't know how much you can see in there. But the one where there seemed to be a pretty consistent signal, there seemed to be fever when they gave these stem cells quite consistently there. Another one that everybody is obviously clearly worried about is whether there was any tumor malignancy rate. The point estimate is the wrong side of the line, although I point out it's very small numbers. You're talking about 5 cases versus 7. And as you can't detect these stem cells after you've infused them in the acute setting, hematologists I work with think that it is safe. They don't seem to engraft. So the feeling is they probably are safe, but clearly we need more data. And again, that same group from Canada published their phase 1 trial, the KISS trial in the Blue Journal earlier this year, where they gave a dose escalation, just 9 patients, a sort of 3+3 design, and they determined there that it was well tolerated with this dose going up to 3 million cells per kilo. And I won't show you all of the data, but just that concern around fever, there didn't seem to be even a febrile reaction in these patients, so they do seem to be well tolerated. And now, again, people are doing phase 2 trials. Michael Mathey's been doing it in ARDS. The Canadians are doing it, and I know the French have studies, particularly in community-acquired pneumonia. So I think this is something we're going to see more of in the future. Now, as I've said already before, it's not just about inflammation. This is reviews taken from Richard Hotchkiss and others, and accepting that what goes on in sepsis, and as I said, it's labeled theory 1 because we don't know exactly, but maybe it's not all inflammation. Some patients clearly do die of acute inflammation, and it may be important to target them. But I think as sepsis care and intensive care, resuscitation in general has got better, fewer patients are dying of that acute inflammation. And actually what is happening is many patients then survive, but then get recurrent infections and stay in the ICU a long time. And can we treat these patients? Well, this is being suggested, and again, this review article goes on to suggest a number of possibilities. We've had trials in the past of really focusing on the innate immune system. So interferon, GM-CSF, which has perhaps had some signal for benefit in particular patients. But now also people are suggesting that maybe we should focus on the adaptive immune system. Evidence that sort of that is affected, particularly low lymphocyte counts, is associated with the worse outcomes in our septic patients. And so we could treat that maybe with IL-7 or anti-PD-1, PD-L1 antibodies. And again, these trials are starting to appear. So I think this was in March, published now, the first trials of IL-7 given. Randomized controlled trial in sepsis, small numbers again, less than 30 patients been treated. All had low lymphocyte count on admission. And they were randomized to 2 doses, either low or a high dose. And you can see here that the absolute lymphocyte count came up more quickly once you were treated with IL-7, and importantly, it was prolonged. Now, again, this is early, a proof of concept study. There's lots we need to learn about the safety. There was concern over rashes, I believe, with the IL-7, and what is the right dose? Do we go with the lower or the high dose? But I think it paves the way for future therapies. As I mentioned, anti-PD-1, PD-L1s, which are used in oncology fields so much, these checkpoint inhibitors seem to be having great effect there. It's being talked about, should we be doing something similar in sepsis? We see many of the same effects. And again, here's evidence of early trials checking pharmacokinetics and safety in human sepsis. So these are all be coming, I think, to us soon. But it's clear we shouldn't be giving them to everybody. I don't think we're suggesting we use this for all sepsis. And that comes back to my first talk this morning about using the gene transcript profiles, this SRS1, which was immune suppressed. Are these the ideal patients that we should be giving these therapies to? So in summary, I just outlined there are clearly other therapies, but the ones that sort of I'm involved with that I think are looking promising. The idea of beta blockers, obviously that's available to us if we want, but I think we need more evidence to know exactly who should get them. The whole TNF story, I think, is sort of been reignited again with using selective blockers, so as we've gained more knowledge there. The whole idea of stem cells, they seem to be used for all sorts of conditions, and I think it's certainly something that we in critical care should we be using them. And then finally, switching that idea of immune stimulation for those prolonged patients on the ICU, can we help them recover more quickly, prevent the nosocomial infections and those long stays in ICU? But it's quite clearly that if we're going to do this, we need to select the right patients for these treatments, and that's where I think we're going in the future. So I'll stop there. Happy to take questions. Thank you.